what is this? What is, first of tell me, what is this sample that I am showed you? Yes, what is this sample? It is a bone marrow aspirate. It is a bone marrow. It is a bone marrow aspirate. Okay. Now I will not tell you what are the individual cells that we see over here, else you will get this thing, but I can tell you this cell is for the myeloid series. This cell is your erythroid series. Okay, this is also your myeloid series. So what is this cell? Which is the largest cell? Yes, can anyone tell me? What is this? Haven't you heard? It is a normal megakaryocyte. Megakaryocyte. And it is the largest cell in our body, and this is a normal. Now, why have I shown you a normal megakaryocyte? Can you see a normal megakaryocyte? When they are mature, they are multi-lobed, having multiple lobes in the nucleus. Yes. And can you see the cytoplasm? Yes, there is lots of this dot, dot, dot. What is this?
Yes, sir.
Platelet. And how is the platelet formed?
Platelet.
Platelets are formed by disintegration of these small spots. Okay, by the fragmentation of the cytoplasm. Are going to read about ITP. So yes, now you tell me once again, what is the full form of ITP? Yes. Idiopathic Thrombocytopenic Purpura. Purpura. It is ITP. It is idiopathic thrombocytopenic purpura. Now remember one thing, idiopathic thrombocytic purpura are of two types. One is your chronic variety and one is your acute variety. Please pay a lot of attention over here because a lot of questions are being asked from ITP, and ITP is a very, very important topic because you will come across such patients throughout your life. Okay. So this ITP becomes very important. As I told you, there are two types. One is chronic, one is acute. Chronic ones are far more common. They basically involve the adults and basically they persist throughout life, whereas this is less common and they usually occur in children. And this one, usually it resolves on its own. Okay. I will be discussing the differences also. So first, let us start with chronic ITP. So there are lots of questions that is being asked, and I will show you a lot of images also over here. Okay. So please pay attention over here. Okay. So chronic ITP, if you see over here, chronic ITP. So let us try and understand about chronic ITP. Now, first tell me one thing, acute and chronic ITP, it comes under which heading? Which type of autoantibodies are formed over here? Yes. Primary autoimmune. Yes or no? Primary autoimmune. So over here, what is happening? Yes. Yes, tell me what is happening over here. The body, our own body is synthesizing autoantibodies, which without any reason, it is going and destroying. Yes or no? It is going and destroying. So this is, so it occurs because of autoantibody mediated destruction of the platelets. And it should occur in absence of any known factor. So it should be idiopathic in nature. So there should be no known cause for the existence of autoantibodies. So you have to rule out whether the patient has taken any drugs. You have to rule out any secondary autoimmune condition. You have to rule out any infection. Okay, that is called as primary. Now, for example, if it is occurring secondary to other conditions like, as I told you, SLE, HIV, or neoplasms, then secondary causes are there. Okay. So remember, the diagnosis of primary chronic ITP is only made after the exclusion of secondary causes. So now the first important thing that we will see with regards to this, and this is an exam question, it is a long answer question which comes ITP. So what is the pathogenesis? As I told you, our own body is going to form autoantibodies which are directed against the platelet membrane glycoprotein. So there are two glycoproteins on the platelet membrane. One of them is glycoprotein 2B3A, or it is the glycoprotein 1B9. Okay. So this is very, very important. If you remember, this 1B9 was involved in platelet. What was the function of this? Platelet adhesion. It used to adhere the platelet to von Willebrand factor in the vessel wall. Okay. Whereas what was the function of this platelet glycoprotein 2B3A? They were involved in platelet aggregation. Please go back and read the basic lecture on hemostasis. Okay, it was involved in platelet aggregation. Okay, so this is, so whatever, what I want to tell you is that without platelet adhesion and platelet aggregation, the bleeding will never stop. Primary hemostatic plug will never be formed. So over here, the antibodies, they are going and they are destroying the platelet glycoprotein 2B3A as well as 1B9. Okay, and such autoantibodies, they can either be demonstrated in the plasma of such patients, or they can be found bound to the platelet surface in about 80% of the patients. Okay, which is very important. And what is the class of the autoantibodies found in ITP? It is IgG class. It is IgG class. All of these are MCQs. Okay, so autoantibodies are directed against what? Against platelet membrane glycoproteins. Where are they found? In the plasma, as well as they can be demonstrated attached to the platelet surface in 80% of the patient. What is the class? It is of IgG class. Okay, now remember, just like in case of autoimmune hemolytic anemia, what happens, that I will just show you, that there is opsonization. So I will just show you with the help of a diagram. So suppose this is the basic platelet and this is a surface glycoprotein. So what is happening over here? This platelet, which is having this glycoprotein on the surface, what is going to happen? They are coated by IgG. Okay, they are coated by IgG. So now what will happen? This platelet is coated with IgG. So what do we call it as? We say that they are opsonized. Yes or no? Now this is going to go into the spleen. It is going to go into the spleen. In the spleen, what is going to happen? So this platelet having this glycoprotein, which is basically coated by this IgG. Now this is what? This is the FC tail. This FC tail will be recognized by who? By the macrophage. By the macrophage. Yes or no? By the splenic macrophage. Yes or no? And this is the FC receptor, which is present on the macrophage surface. They are going to recognize the FC tail of this IgG antibody. And this will cause this macrophage will now, it is going to phagocytose and destroy. Okay, phagocytose and destroy. This is called as opsonization. This is the same concept that we had read even in case of extravascular hemolysis, if you will remember. Okay, very, very important. So thrombocytopenia is usually so as in case of autoimmune hemolytic anemia, as we read, the antiplatelet antibodies, that is this IgG antibody, it is acting as an opsonin. It goes and it will coat the platelet. Okay, it is going to coat the platelet, and they are recognized by the IgG FC receptor, which is present on the surface of the macrophage, leading to increased platelet destruction. I think this concept is very clear. From the very beginning, we have been thorough with this particular concept of opsonization. Okay, so this is how the platelets are destroyed by the spleen. Now, one very important thing is that the thrombocytopenia that occurs over here is highly, it is usually markedly improved by doing splenectomy. It is indicating that the spleen is the major site of removal of this opsonized platelet. So if you remove the spleen in such patients, the platelet destruction comes down. Now, there is also one theory that spleen is also the source of autoantibodies. So removing the spleen will serve two purposes. It will cause lesser destruction of platelets, and it will also remove the source of autoantibodies. So there is a twofold advantage of removing the spleen in ITP. The first advantage is what? That the destruction of platelet will come down because opsonization will not occur. And the second important thing is there is a removal of the source of autoantibodies. Okay, is it clear to everyone? Now we will come to the morphology of this. Now morphology, before I go into the theory, I want to explain you, okay, over here. Now, look at this particular peripheral blood stream. Okay, what are these? This is the PBS, which has been taken from the patients of ITP. Okay, so what is this? Yes, everyone tell me, what is this?
Platelets.
Okay. Now I am going to ask you about one thing. What is the significance of this platelet? Why am I showing you this platelet? How is it different from the normal platelet? Yes.
Size.
So there is increase. So these are actually giant platelets, and usually 1 or 2 giant platelets might be present in normal persons like you and me. But over here, most of the platelets, they are giant. So what is the significance of giant platelets? The presence of giant platelets suggests that there is an accelerated thrombopoiesis. Thrombopoiesis means there is an excessive production of platelets. Now, why will there be an excessive production of platelets? Yes, can anyone tell me? Why is there an excessive production of platelets? Because somewhere down the body, there is an increased platelet destruction. Okay, increased platelet destruction. Okay, so whenever there is an excessive amount of platelet destruction, there will be increased release in which hormone?
Thrombopoietin.
Thrombopoietin. And this thrombopoietin is going to stimulate excessive amount of platelet formation. And when it happens in excess, what will happen? The quality will be compromised, yes or no? Just like in case of erythropoiesis, when there is an excessive amount of erythropoiesis, what happened? In the circulations, you will find NRBCs. You start seeing excessive reticulocytes in the circulation, yes or no? Whenever there is an increased erythropoiesis, we see these two things. Similarly, when there is an excessive amount of thrombopoiesis, we are seeing giant platelets. So giant platelets, it is a marker of accelerated thrombopoiesis, which is indicating that there is an increased platelet destruction. Okay. So is this clear to everyone? What is the meaning of giant platelets? Yes, if anyone asks you, you can answer now. Okay. Now let us corroborate to our findings over here. Okay. So what is this? What is this? First of tell me, what is this sample that I am showed you? Yes, what is this sample? It is a bone marrow aspirate. It is a bone marrow. It is a bone marrow aspirate. Okay. Now I will not tell you what are the individual cells that we see over here, else you will get this thing, but I can tell you this cell is for the myeloid series. This cell is your erythroid series. Okay, this is also your myeloid series. So what is this cell? Which is the largest cell? Yes, can anyone tell me? What is this? Haven't you heard? It is a normal megakaryocyte. Megakaryocyte. And it is the largest cell in our body, and this is a normal. Now, why have I shown you a normal megakaryocyte? Can you see a normal megakaryocyte? When they are mature, they are multi-lobed, having multiple lobes in the nucleus. Yes. And can you see the cytoplasm? Yes, there is lots of this dot, dot, dot. What is this?
Yes, sir.
Platelet. And how is the platelet formed?
Platelet.
Platelets are formed by disintegration of these small spots. Okay, by the fragmentation of the cytoplasm of the megakaryocytes are the platelets formed. Can you see one platelet here? Can you see one platelet here? They are fragmenting from the cytoplasm. This is how normally platelet form. Now, I will not go. Why have I told you so many things over here? So that now the next thing becomes clear to you. Okay. Now, this is a bone marrow biopsy, which is taken from a patient of an ITP. Okay. Now, what do you see? What do you understand from here? What do you understand? In one picture, you are seeing what are these structures which are marked? Yes. What are all these?
Megakaryocytes.
Megakaryocyte.
Yes. So there is an increased amount of megakaryocyte. Okay. So in case of a thrombocytopenia because of ITP, in the peripheral blood smear, you are seeing giant platelets. There is a thrombocytopenia, but when you do a bone marrow study, you see that the amount of megakaryocytes are more than normal. So what does it indicate? This excessive amount of megakaryocyte is indicating what?
Excessive destruction of platelets.
It is indicating accelerated thrombopoiesis. Okay. So there is an excessive production of platelets. And why is there an excessive production of platelets? Because somewhere down the line, the platelets are getting destroyed. So a peripheral blood smear showing a thrombocytopenia with a normal bone marrow showing an excessive thrombopoietic activity with increased megakaryocyte is a classic sign of ITP. Will this thing be completely always be clear in your mind, everyone? Yes? Yes? Is this concept clear to everyone? Now I will show you this. Now I will tell you why it is called as an increased megakaryopoiesis. I showed you normal megakaryocyte. A normal megakaryocyte, the nucleus of this is lobulated and they are mature. Can you see the nucleus of this particular platelet? Just let me take some other pen. Can you see? This is also from ITP. Have they shown any lobulation? Is there any lobulation?
No, sir.
So the
No, sir.
so the megakaryocytes are not mature. What is it indicating? That there is an excessive thrombopoietic activity. So when the activity becomes excessive, the maturation is not true. Okay, not correct, because they are not getting the time. Because as soon as the platelets are formed, they are getting destroyed. So what happens in case of a war? In case of a war, when the number of trained professionals are less, even all men from all the houses, fathers and brothers, they are also encouraged from all families to join the war, even if they know or if they don't know. So they will not have the characteristics of a true soldier, yet they will be asked to fight the war. The same situation is in our body. Okay, so these megakaryocytes inside the bone marrow, they are non-lobulated. Okay, this is non-lobulated, so you do not have to mug up anything. I have shown you everything with the help of diagrams, so it should become very clear to every. Okay, so now I will read each and every point. Now you tell me if you understand or no. The first thing always that I will do is the peripheral blood smear. I will start with. Okay, so peripheral blood smear is going to show thrombocytopenia, means there will be reduced platelet count. Okay, thrombocytopenia, it is the first thing that we are going to observe. The second thing is that we are going to see the presence of giant platelets along with thrombocytopenia. And the presence of giant platelet, it is a sign of accelerated thrombopoiesis. Yes, everyone will agree with me on this. Okay. So after you are going to find this picture, now you want to understand why is this thrombocytopenia because of. Okay. So now I am doing the second line of investigation. I go for a bone marrow study. So when you see the bone marrow, you are quite surprised. First of all, you see inside the bone marrow that there is an increased amount of megakaryocyte. So now you know that there is no problem in the platelet production. The production is absolutely all right. The basic problem is lying in the platelet destruction. Okay, because of which our body is thinking to produce excessive amount of platelets. Okay, not only that, because our there's an accelerated thrombopoiesis, you are going to see some of the megakaryocytes, they are immature, they are large and non-lobulated single nucleus. Yes or no? See over here, have I not shown you this? So all these are features of accelerated thrombopoiesis secondary to platelet destruction. Okay, now is the point very clear? When you and how you are going to diagnose a case of ITP? Everyone, you write about spleen or you don't write is not important, but you have to start with the peripheral blood and you have to write these two features when you're writing an answer on ITP. Is this very clear to everyone? Yes. Okay. Okay. Now, what is the importance of doing the bone marrow? Now, over here, for example, I did the bone marrow study. And over here, what happens if there is an excessive thrombopoiesis, if it is taking place, okay, then it is a case of an ITP, I can say. But for example, if for example, there is a reduced megakaryopoiesis, so there is a decreased platelet count in the peripheral blood smear, in the bone marrow, if I see that there is a decreased megakaryopoiesis. Okay, so what is the importance of bone marrow? Decreased megakaryopoiesis is indicating that there is a bone marrow failure. There is some problem at the level of the bone marrow. Okay, so we have to differentiate whether the problem is lying at the level of the bone marrow or there's a problem in the body itself. Okay, so is this understood to everyone? Very clear? Okay. Now we are going to understand what happens in the spleen. So basically in the spleen, if you see, the spleen is of normal size. There is some amount of congestion in the splenic sinusoids. The splenic follicles also enlarged. Can anyone tell me why the splenic follicles enlarge? Yes, why is the splenic follicle enlarging? Yes.
Because of increased phagocytosis.
Yes, there is an increased phagocytosis. Plus, I told you the spleen is also the site of production of autoantibodies. So the amount of B cells, where does the B cell reside? They are residing in the follicles, yes or no? So this enlarged and prominent germinal centers are indicating an excessive autoantibody production. Okay, very important. Okay. Also, some amount of extramedullary hematopoiesis is taking place in the spleen, and this is taking place because of elevated amount of thrombopoietin. And why thrombopoietin is elevated, you all know why it is. Okay. Is the chronic ITP clear to everyone? Yes. Any doubts with regard to chronic ITP? Okay. So we are going to basically discuss what are the features of chronic ITP. As I told you, listen to these features very carefully. These are involving adult women around 40 years of age. And the male is to female ratio, if you see, it is much more common in females. The ratio of 3:1. It is very gradual in onset. Okay, gradual in onset, characterized by pinpoint. Now, I'm not saying again, anything which is to do with vascular valve abnormality or because of platelet abnormality, they will be petechiae purpura. So these are very mild. The thing is, we want to say that these are mild. Sometimes these bleeding can become more in the form of ecchymosis. So there will be always be a history of easy bruising, nosebleed. Okay, there will be epistaxis, gingival bleeding. Okay, melena, hematuria. Because I told you, whenever there is a problem with the platelets, there will be GIT or GUT bleeding. That is gastrointestinal tract bleeding or genitourinary tract bleeding will be there. Remember, severe forms of hemorrhage in vascular wall abnormality or in platelet abnormalities is very rare, It doesn't take place. Okay, just remember this thing. Okay. Now, one other thing is that typical what findings are reflective of an isolated thrombocytopenia. Let us see. Now, first of all, what I am going to do, PT-APTT is normal. What does it mean? There is nothing wrong with the coagulation system. Okay. What other thing I will see in the peripheral blood smear? What did I say? First, I will see if there is thrombocytopenia. Again, in the PBS, I will see there is a large platelet, giant platelets are present. If this is confirmed, I will go for a bone marrow study. What was there in bone marrow? Normal or increased megakaryocytes. Okay, and many of them are having non-lobulated nucleus. Yes or no? Okay. And also very important thing, there is an increased bleeding time. So increased bleeding time, they are taken as a presumptive evidence of accelerated platelet destruction. Okay. So remember, bleeding time is also increased over here. Okay. Is this clear to everyone? All these points, lab diagnosis is clear. Can we go to acute ITP? Yes. Okay, the treatment part I'm not telling you because they do not form part of pathology, but you can read it because they are also asked in the MCQ. So it is easy enough, not very difficult. I will just see, because it is an autoimmune condition. So to suppress any autoimmune condition, there's an increased inflammation. So you give glucocorticoids. Second thing is, spleen is the site of destruction and the source of antibodies. So you have to do splenectomy. Before you will do splenectomy, what you should do, you should vaccinate the patient with 2 vaccines. I have told this in sickle cell anemia also. So I'm not repeating once again. You can give IVIG. IVIG is nothing but these are antibody against antibodies. Okay, so these are antibodies formed against your antibodies. So these are used only in those cases where these two things do not work. Usually we use glucocorticoid as the most common line of management and the first line of management. And lastly, you can give some thrombopoietin mimics. TPO mimetics can be given, which can cause increased thrombopoiesis. Okay. Now the last leg of today's lecture, we are going to complete with this part, that is what is acute ITP or acute immune thrombocytopenic purpura, ITP. So what is the basic thing? One basic thing remains clear over here, that it is caused by autoantibodies against the platelets. But what is different, as the term is that chronic was more gradual, this is more acute. And chronic was more common in adults, whereas this is more common in childhood. And chronic was more common in females, whereas this is occurring with equal frequency in both the sexes. Okay. Now the symptoms are going to appear abruptly over here, whereas the symptoms were more gradual in case of chronic. And they occur 1 to 2 weeks after a self-limited episode of a viral infection. So there is some sort of a trigger which is there over here. Okay. And remember, acute ITP for most cases, they are self-limited and they can resolve spontaneously within 6 months of time. And even no treatment is required. Now, if the thrombocytopenia is persisting beyond 6 months, only then we are giving steroids to the patient, else no. Now, 20% of these children, they they might have a persistent form of thrombocytopenia, and they might proceed to a chronic form of ITP, which is seen in adults. Okay, so this is all about that we want to read in today's lecture. Any doubts you all are having with regards to the understanding of today's lecture? Yes, everyone. Any doubt?
No, sir.
Okay, so today we have discussed the vascular causes of thrombocytopenia, vascular causes of bleeding. We have discussed partly, okay, in thrombocytopenia because of decreased production, yes, and we have also discussed because of increased destruction of the platelets. Now, in the next lecture, we are going to, so we have already discussed the immune mechanisms of platelet destruction. In the next lecture, we are going to start with the non-immune mechanisms of platelet destruction. Okay, so you are highly encouraged to go back and read this lecture, and also encouraged to go back and read. I will share you this entire part 1 will be shared. So you go and read even for next lecture as well from before. So it will become very easy for you to understand. Is this crystal clear? No doubts? Okay. Then I am going to conclude today's lecture. Okay. Thank you very much, everyone.
Thank you,
Thank
sir.
you, sir.
Thank you, sir.
Okay.
Thank you.